This program is a presentation of UCTV for educational and non-commercial use only.
I just want to outline where I'm going to be going in my talk today. Every aspect of medical care involves trade-offs. There are risks, there are benefits of everything that we do. We tend not to discuss many of these when we're talking about medical imaging, but it's the same for everything we do. We need to think about overall what's the benefit of what we do, what's the harm, what's the cost. And the purpose of my talk today is in no way to provide an overview of all of the risks and benefits of medical imaging. This is a huge part of current medical practice, and it's just too large of a topic to even consider addressing in such a short time period. There are two focuses of my talk today. First, I'm going to provide a little bit of an overview of one of the issues that I think it's important to think about for medical imaging, and that's its associated radiation exposure and the potential for causing harm from this radiation exposure. And second, why I believe that this harm is sufficient to warrant the consideration of health policy solutions to improve the utilization and safety of imaging. So we don't usually think about health policy interventions, if you will, for most of healthcare, and I want to make an argument for why I think this is an area where it is important. So I'm going to give you a brief overview of ionizing radiation, what it is, what exposures are in the U.S., and what's known about the harmful effect of radiation. I'm going to give you some taste of what the radiation doses are from medical imaging to sort of bring you up to speed that these doses are, in fact, in the range that we need to be concerned about them. What I think needs to be done to reduce current exposures and why this is an area for health policy interventions. And then I'd like to highlight some of my personal experiences of using the media, health quality organizations, professional organizations to try to deliver messages about health policy related to medical imaging with the goal of trying to help translate evidence into improvements in policy. So just as a background, we've been reading quite a lot about radiation, obviously the last couple of weeks because of the unfortunate events in Japan. Ionizing radiation is defined as energy in the form of high-speed particles and electromagnetic waves, and specifically that have enough energy to change chemical bonds. They remove electrons from the orbits, and this can therefore cause damage. There are lots of different sources of ionizing radiation to the U.S. Population. Some we know about, some we don't know about. Some are naturally occurring, some occur due to their uses in different industries, science, and in medicine. In medicine, the two kinds of radiation we talk about are X-rays and nuclear medicine studies. Nuclear medicine studies, a small amount of radioactive material is put inside the patient. It's injected into the patient, it's swallowed by the patient, and then we detect the radiation that's given off. For X-rays, we take X-rays and they go through the person and then detect them when they come out the other side. The primary concern for radiation within the range of normal exposures are that it's carcinogenic, that radiation can cause cancer. At higher doses, so the kind of doses that people are getting inside the nuclear reactors in Japan, you get acute reactions, you get burns, you get tissue damages, you can get acute death, but that's not usually what we're talking about for most of the exposure to radiation. It's basically a future risk of cancer. So to give you a sense of some of the exposures that we get, until recently, the largest exposure was from radon. It's emitted into the air from rocks. Overall, the U.S. population gets about 2 millisieverts per person per year from radon. And then I've listed a couple of other numbers up here. Exposure to the sun, on average, contributes the next highest dose, about 0.27 millisieverts. The airport scanners that we hear a lot about give you a dose per scan of about 0.00001 millisieverts, so a pretty tiny dose when looked in the context. And then I've listed a couple of medical imaging tests. A chest X-ray, 2 views of the chest, give you a dose of 0.06 millisieverts. A CT scan of the chest gives you a dose of 8 millisieverts. So if you look up there, you'll see that 8 kind of stands out as higher than the other numbers. And then some types of scans that we do, for example, a CT scan the chest, abdomen, and pelvis, which we would do frequently in an emergency department setting where we just scan the whole body, the dose can be up to 100 millisieverts. So that's on a single scan, a pretty high dose. I'm showing you here, the upper left is a distribution and radiation exposure of the U.S. population that was conducted in 1985, a summary, and the bottom right is 2006. And I'm showing this to show you that the radiation exposure of the U.S. population has increased pretty dramatically due to medical imaging. So in the upper left corner, in 1985, the average total annual exposure was just under 4 millisieverts, 3.7 millisieverts. 3/4 of that came from natural sources, mostly the sun and radon, and 25% came from medical imaging. If we shift to 2006, the total exposure on average is 6 millisieverts, so nearly twice as high, and now 50% are from background sources and 50% from medical imaging. And you notice there's a large blue triangle in the image on the bottom that wasn't there before. That's CT scanning. So CT scanning basically has by itself led to a doubling of the population's exposure to medical imaging. So the doses are substantial. In terms of what we know about whether or not this exposure to radiation is harmful, I'm going to go through a bunch of slides from a report published by a group that was sponsored by the U.S. National Academies of Sciences. And this report is by far the most widely cited. It included on the committee that generated this report leading scientists from across a whole wide range of disciplines. And in this report, they both estimated doses very precisely and then used every possible bit of information to estimate what we'd expect in terms of harm based on this exposure. And I'm going to go through this just because I'd like to establish that the information of what we know about the carcinogenesis of radiation is very well established. In fact, there's been no other anything that's been studied in such great detail in terms of the depth and the number of publications. So a lot of the information about what we know about the harmful effect of radiation comes from the Japanese atomic bomb survivors, and these provide the best estimate of what we know about low-dose radiation. And it relies on basically survivors of the atomic bombs, 120,000 survivors, and these individuals were at markedly increased risk, are at markedly increased risk of getting cancer. I want you to sort of think about these numbers as I'll come back to them, but the median dose of survivors of the atomic blast was 40 millisieverts. And that's sort of the same kind of ballpark as some of these imaging exams can deliver. The studies of the survivors looked at very carefully estimated organ-specific doses, so what were the doses to different individuals to the breast, and what was the risk of their breast cancer? What was their dose to the bone marrow? What was the risk of their bone marrow cancer, leukemia? And the associations are really dramatic. At every cancer they looked at, and there have been literally thousands of reports of this population, there's an increased risk of cancer. At doses as low as 10 millisieverts, survivors are at increased risk of getting cancer. At lower doses, 2, 3 millisieverts, people who lived further away from the explosions, they're not at increased risk. At 10 millisieverts, they are. Unrelated to this large literature of the atomic bomb survivors, there's a very large population of papers that have studied patients who have been medically irradiated for malignant disease. We use radiation in the treatment of about 50% of U.S. patients who have cancer. Following high-dose radiotherapy for malignant disease, across nearly all cancers, there's an increased risk of radiation-related second cancer. So it's not that they're at increased risk of cancer because they have cancer. The studies separate cancer survivors who were radiated, who were not, and patients who get radiation are at high risk of second cancers. Second cancers are particularly high among survivors of childhood cancer who receive therapeutic doses of radiation. So among children who have Hodgkin's disease, one of the leading causes of death in these children is new cancers that occur 10 or 20 years down the line. There was also a lot of radiation used for benign disease in the 1920s, 30s, 40s, and 50s. The radiation we used across a whole range of benign conditions, things like fungus or rashes or tonsils or enlarged thymus, postpartum mastitis was routinely treated with radiation. And there have been, again, many papers among lots of these populations, and these populations are at increased risk of getting secondary, or primary cancers, I should say, in the areas that they were radiated. So patients who got thyroid radiation are increased risk of thyroid cancer, breast radiation, breast cancer, and so forth. There are also groups of patients who it wasn't so much benign disease, but the x-rays were used for the treatment of various underlying disease or to diagnose underlying disease. So women who had scoliosis got very frequent x-rays in childhood. They might have had x-rays every few months, and they might be full spine x-rays, so the doses could be pretty substantial. Patients with tuberculosis were treated with procedures that required ongoing surveillance. Children who have cardiac disease at birth often undergo repeat angiography studies, leads to high doses from those diagnostic tests. And all of these groups have been found to have higher rates of cancer than you'd expect in the absence of radiation. And then there are whole subgroups of patients who might be particularly at risk, mutation carriers who are particularly sensitive to radiation changes. Unrelated to the medical field, there's a large literature about radiation workers. So, for example, there have been a few studies. The one I cite here is nearly 500,000 individuals who work in the nuclear industry. Average doses of about 20 millisieverts over many years of exposures have been reported. Again, these are kind of the doses that we can see with CT. And there's been a significant association between exposures to these levels and the likelihood of dying of cancer. There are several studies I had the opportunity to participate in last year when I was a visiting scientist at the NCI that had followed medical workers, technologists, physicians who work with radiation, and certainly there's a suggestion of an increased risk of cancer in these populations as well. So in summary, I think the evidence of the harmful effects of radiation is pretty persuasive. There's a very large epidemiologic literature. I haven't cited it, but there's also a very large basic science literature that shows that the exposure to radiation leads to the development of cancer. The data are highly consistent across studies, and there have been some very widely cited quotes on the safety of radiation. Many of these have been issued by the radiology professional organizations that have said that it's not scientifically demonstrated that any cancer risk exists below 100 millisieverts. These are simply untrue. The literature is really very persuasive. And so I think the exposures in medical imaging are clearly in the range where there is an increased risk of cancer, and therefore we need to be cautious about how we use this technology. In terms of medical imaging, 3/4 of medical imaging tests that we now do expose patients to radiation. None of these risks of radiation that I've now cited in this literature are new. And many of the early radiology pioneers developed burns or died from radiation-induced cancers. But what is new is the dramatic increase in exposure to radiation. And that comes from the increased use in CT, the technological changes of CT that have worked together to increase our exposure to radiation. So I'm going to go through for medical imaging what are some of the observed doses for CT and why I focus on CT rather than all of medical imaging. CT overall is about 10 to 15% of medical imaging. What are patients' cumulative exposures over time, and how has this changed over time? So CT uses X-rays to obtain very detailed images of internal organs. As compared to a typical X-ray, like a chest X-ray, an abdominal X-ray, where the X-ray comes from the front, is collected in the back, one set of images. For CT scanning, X-rays are delivered circumferentially around a patient as she moves through a table. So lots and lots of X-rays are used, and then very sophisticated, complex computational techniques are used to generate three-dimensional images. The radiation doses associated with CT are inherently much higher than conventional X-rays because so many X-rays are delivered at once, and those can be 100 to 500 times higher depending on what part of the body is imaged. So we published a paper at the end of 2009, and I want to show you just a few of the numbers that we found in terms of what kinds of doses are associated with medical imaging. We organized the tests by what the indication was for the scan. So if a patient was sent for a CT scan of the brain for one indication, we grouped it differently than from another indication. So head, we had a routine head versus a patient who was sent for a suspected stroke. Or for chest, we looked at a routine chest, someone who was sent for a suspected pulmonary embolism or a coronary angiogram. And we learned that the doses that we found in actual practice, and this were actual practice in 4 Bay Area hospitals, were actually higher than is generally cited to be the case. So a routine head, while cited to have a dose of 2, and typically estimated doses are 2 to 3 millisieverts, if a patient was sent for a rule-out stroke CT, the dose was 14, so substantially higher based on why the person was sent. In parentheses, I've given you the range of dose, so typically estimated that a CT of the head has a dose of 2 to 3 millisieverts, but in fact, depending on why the patient sent, it would be between 4 and 56. So that's a really broad range for a study. If we look at abdomen, the last example, abdomen CT is the most common CT we do in the U.S. We generally quote it as having a dose of 8 to 10, but the average for a multi-phase study, a very common type of exam, was 3 times higher, 31, and the range was 6 to 90 millisieverts. So some patients had a dose that were in the ballpark of 10-fold higher than we typically say the study is done for. And we looked to try to figure out why the doses were so variable, and it was really tricky to figure out reasons that made sense of why it was so variable. On this slide, I'm putting the doses just into the context of some other exams we do. Chest X-ray is the single most common exam we do in the U.S. It accounts for nearly half of all imaging tests, and it's followed by mammography, the next most common exam. And if we look at a multi-phase CT, the mean dose of 31 millisieverts is the same as 442 two-view chest X-rays or 74 mammography series. So at some point, patients were concerned about the radiation dose for a mammogram. A CT scan of the abdomen is the same as a patient coming in 74 days in a row and getting another mammography series. I showed you the range of doses for these exams. I'm showing you in this slide the mean dose across the 4 sites that we included in our study, so site 1, 2, 3, and 4. And the mean dose for each study type varied substantially across the setting. So for suspected stroke, site 3 had a dose of 8 millisieverts, whereas site number 4 had a typical dose of 29 millisieverts. And on average, the variation I've shown in this last column was around 15 or 20-fold difference between the different settings. So that's a lot of variation when we're talking about a dose that's this high. And this is just shown graphically. Each of the box plots shows a different examination. The last 3 are the 3 abdominal examinations we looked at. The red line is showing the dose that we typically cite this examination as having at about 10 millisieverts, and then the box plot is showing the distribution in actual patients. You can see for the multi-phase abdominal exam, the actual dose is 3-fold higher than we cite, and the range in dose was pretty dramatic. And there are lots of reasons the doses we found were likely different than those that are cited. I'd say the most important reason is what we know about the doses that patients receive is generally from studies that are called phantom studies. These are studies that are done on very sophisticated plastic models that are put in a CT scanner. We measure dose, and that's what we think the dose is. But when you do studies on actual patients, you don't necessarily follow those protocols. This is what we learned, that those phantom studies don't necessarily reflect other real patients. And we've actually subsequently collected dose on 10,000 patients, and the numbers actually just show much more variability than even we presented in this initial report. So the doses in summary for CT are 1.5 to 5 times higher than widely cited. The doses are highly variable. They vary between patients and between sites. And again, we've had ongoing work that really shows that we've just identified the tip of the iceberg. And I don't have a lot of time to go into this, but the doses are higher than they need to be. There are current ways to reduce the doses, profoundly without impacting the capacity to make accurate diagnosis. So why are the doses so high and so variable? I'd say the most important reason is we have no clear dose targets that are set for CT in the United States, and this contrasts really dramatically to what's the case in most European countries, in Canada, in Asia, where very clear targets are set for what is an acceptable dose amount. There's no professional organization or government organization responsible for either collecting or reporting dose data, and no clear quality standards exist. And it turns out in the U.S., radiologists are largely not aware of the doses that they typically use. And so there's sort of no one in charge, and then the people who are setting the parameters don't really know what the doses are or what they should be. And then I think it's been very ironic, but that there are technical components of CT that have led to an increased dose for a growing proportion of examinations. So I started by saying that the doses of CT are inherently higher than X-rays, but they're also going higher and higher due to improvements. Helical multi-detector, multi-phase scanning has become possible the last couple of years due to improvements in CT that largely have reduced the time it takes to conduct an examination. So it used to take many minutes to scan a patient from their head, just through their head or through their chest or their abdomen. And now you can scan that entire range in a matter of seconds. You can scan the entire body in seconds without overheating the machine. Partly that has led to more uses for CT because it goes so quickly we now can look at moving vessels where we couldn't in the past, but it also permits the development of very complicated protocols that allow looking at many other parts of the body at the same time, many phases of the cardiac cycle, and this has led to higher doses. And the detail, in general, this is sort of an overstatement, but increases in proportion to dose. And the manufacturers have competed for the last several years on the clarity of the images. So they've tried to make the images clearer. They're selling the machines to radiologists who really like looking at clear pictures, and the doses have been going up. And it's sort of changing the last year or so, but the principal way that manufacturers have competed when they're selling their CT machines is on this image quality. And so if you went to several of the very large radiology meetings, you'd see phenomenal images that really are greater than actually dissecting the body, but those come at a pretty big price in terms of the dose. And the pressure to generate increasingly higher quality images, once you've sold a CT scanner, your goal is then to sell that person another better CT scanner. You have to show that it's better. And that's been on image quality. So as an example, the brain perfusion scans that got so much attention because of the radiation overdoses at Cedars-Sinai and then increasing number of hospitals uses something called a brain perfusion scan. And that type of scan leads to a dose that's 10 times higher, when it's done correctly, than the dose of a routine head CT. So even when done well, it's 10 times the dose of a routine head CT. When done incorrectly, the doses are 100 or a few hundred-fold higher. But this kind of new technology has been advocated, and in many cases, there hasn't been a lot of evidence that this has really led to improvements in diagnosis. There are remarkably few guidelines of how to use these new high-dose studies. And practice variation, of which there's dramatic variation in the use of these high-dose techniques, much more reflects physician practice preferences, the manufacturers pushing the different type of scans, rather than evidence that patients do better, that there's improved diagnosis using these. And I think public health concerns really have not been paramount to those who are asked to buy imaging equipment. Radiologists like looking at beautiful pictures. We don't tend to get a lot of training in epidemiology or cancer risk, so we're not really that sensitive, and we're choosing the images that really lead to the most beautiful images. The manufacturers, therefore, are promoting this, and the idea of the dose really has gone the wayside until recently. In Europe, that hasn't been the case. In Europe, these protocols are not promoted to the same degree because there's much more awareness of dose, and there has been for over 15 years. I wanted to give you sort of an example of what some of these differences in the appearance of the scans look like. On the left is a patient who underwent a CT scan to follow up a pulmonary nodule that was seen. It was actually a patient in the National Lung Cancer Screening Trial. They saw a small nodule in the trial, and then they said, oh, we don't know what this is. You have to follow the patient. And can everyone see the nodule? the top is the image of the lung, and the bottom are the images that we took through the abdomen in this patient. And the patient underwent a low-dose CT scan, actually like called for in that protocol, and the dose was 1.5 millisieverts. This is the same patient who underwent follow-up 1 year later, but this time underwent a clearer picture, a routine chest CT. Can everyone see the nodule on this picture? So this is a complicated question, but can anyone see the nodule better on the right than they can on the left? I mean, I can't. Now, I can see in the abdomen picture that the images on the bottom right are prettier than the images on the bottom left. So the fat is kind of distorted a little bit in this picture, but it's cleaner in this picture. And this is a routine study. This is not a study that went awry. This is what we do every day. And I think we need to start thinking about, well, how do we get patients to get this dose when, in fact, much more often we get that dose instead? So in terms of the oversight of CT, despite the potentially harmful radiation doses CT can deliver, there is no oversight. There's no professional or government organization who's responsible for collecting, monitoring, or reporting dose information. The FDA oversees the approval of CT scanners, so to make sure that the scanners themselves can't malfunction. We've had some problems with that, and so they're changing what they're doing in some ways, but they don't have regulatory oversight for how the tests are used in clinical practice. Radiologists and increasingly other medical specialists, urologists, cardiologists, surgeons are purchasing CT scans. They determine how the scans are used in clinical practice, but there isn't really a sense of either knowledge of how to lower the doses, nor are data being collected that would really help them understand what needs to happen, what is a target. This is in the area of the practice of medicine, and so there's a lot of independence by physicians to be practicing in independent ways, and yet, in this case, I think there's really a need to come up with some standards that at least the radiologists and other specialists can apply. And there have been several studies that have asked radiologists or other specialists what they know about radiation, and the bottom line is they know almost nothing. So clearly a disconnect between the people who are in charge of making sure the equipment is safe and what they actually know. And again, this contrasts really starkly with other countries where both professional groups and government oversight exists, and very close oversight. There are no standards of how these exams should be conducted. So I've shown you some information about what typical doses are, what they're cited at, but to find out what a good dose is in the United States is almost impossible. There is a general principle that's supposed to guide how we use radiation, and that's called ALARA, and that's means that doses are supposed to be as low as reasonably achievable. But I would argue that there are no guidelines about what are reasonable or what's achievable. And we're having every single institution reinvent the wheel about what we should be doing. In the absence of explicit guidelines, practice variation can, and I think will be leading to unnecessary harm from excessive radiation doses. And then the people who really are the people who are closest to what gets delivered to each patient are the technologists, and there are no national standards or educational requirements for technologists who conduct CT scans. And it's medical imaging in general, I should say. It's pretty striking, the absence of these standards. So I've given you some information about what these doses are. Are these doses high enough that really there should be concern at a broader level outside the radiology community? Is there enough information about risk that there really should be attention to this? So we're going to pretend you all have those audience response software panels in front of you. What's the risk of cancer associated with a multi-phase abdominal pelvic CT scan in a 20-year-old woman? Risks vary by age, so 20-year-old is a higher risk than an older person, and this exam that I'm asking you about is the most common exam that we conduct in the U.S. So is the risk of this test that 1 in 100 patients will get cancer, 1 in 1,000, 1 in 10,000, 1 in 100,000? So by show of hands, how many think the risk is about 1 in 100? If you get a CT scan, you'll get cancer. I got 1 there. How about 1 in 1,000? 7, I think. 1 in 10,000? 7-ish. And 1 in 100,000. I think 1 in 100,000 is kind of a good number. I'd like 1 in 100,000, but that's a pretty low risk. Whereas 1 in 100, to my mind, is a pretty high risk. And you're thinking if you're doing a test to find a disease, you don't want it to give you the disease. In our work overall, I'm showing you a little bit of a complicated graph, but sort of gets the answer to that. This looks at the actual doses that patients were exposed to in our study, and I've sorted the patients. These dots reflect the doses that were received by an individual patient, and they're sorted from the lowest dose to the highest dose. And on the y-axis, I've calculated the lifetime attributable risk of cancer from a single test. And I should say, if someone undergoes a CT scan in a year, they're likely to undergo 2. That's the median amount. So no one gets 1, you get 2 in a year. But based on a single test, the multi-phase scan is this top line. The dose that was received by the middle person, half the people got a higher dose, half got lower, led to a risk of about 1 in 250. So 1,000 such women, 4 of them would get cancer. So about 1 in 250, between the 1 in 100 and 1 in 1,000. But if you look at the highest risk person, this person got a high dose for no reason related to her illness, she had a risk of 1 in 80. So this one exam gave her a risk of about 1 in 100 of getting cancer. And that's a very high risk given our current capacity to lower the doses. So I would argue that, yes, the current doses for CT are in the range where really they merit further consideration, and I think that consideration needs to be from organizations that get involved in health policy. I think this is only one of the 2 questions I have for you. So doses for CT scan are high and they're increasing. But a big part of why the doses are going up to the population is not the dose per exam, but just how many of these tests we're doing. So in 2007, how many CT scans are we doing? 1 in 5 patients per year, 1 in 10, 1 in 100, 1 in 500, or 1 in 1,000? So how many people think that 1 in 5 people undergo a CT scan per year? I mean, that's a lot, but okay, that's a good guess. 1 in 10? 1 in 100? And you work in a medical center, I'm surprised. Okay, 1 in 500 and 1 in 1,000. So we have several papers where looking at how many tests we're doing. And so I'll just share one of them with you. This one is looking at testing in an HMO setting. This is looking at 7 integrated healthcare systems across the country. This particular set of data is looking at about 2.5 million members who enrolled for 15 years across the HMOs. We looked at use of medical imaging, CT in particular. We looked at radiation dose. This is where we've collected the thousands of dosing from. Imaging with CT increased 3-fold over the years of this study. Radiation exposure increased 3-fold, but there was a 10-fold increase in those group of patients who got high doses, and the doses, again, were higher than is known. So this is a graph that shows how many CTs were done. Each of these lines reflects a different healthcare system. So one of those systems is Northern California Kaiser. One of them is Marshfield Clinic. They're very large healthcare systems. And the dose of the number of patients who underwent CT increased from about 5 per 1,000 at the beginning of the time period to 250 per 1,000 patients at the end of the time period. So about 1 in 4 patients got a CT scan every year. And these numbers are pretty high given that we think about CT as a population as studies that are done in really sick patients in whom really need the CT scan. Or patients who undergo surgery and we want to figure out a complication, or patients who have cancer and we want to stage them, or patients who have been in a major motor vehicle accident. So those are the patients we think about who it's very clear that there's benefit of CT, but we're now doing CT in 1 of 4 patients a year. So we're doing a lot of CT. Adults are the top group of lines, same information on the bottom group of lines. Those are children. Doses, use of CT is much lower in children, but it's also going up at the same rate. And then I've looked at this in lots of different ways. Each of these is showing a different age group and is showing the increase in imaging over time. So within each age group, imaging is going up at a pretty dramatic rate. It's not just one group of patients who are getting imaged. For example, the elderly who may have a lot of diseases. We're really increasing it in every group possible. And put into the context of other sort of industrialized countries, the rates of imaging are very high in the U.S. In terms of how much money we're spending on this, physician payments for imaging has increased at twice the rate of overall physician expenditures over the last decade. So this is a big piece of sort of where the rise in healthcare costs. And related to this, there's a lot of interest among insurers, CMS, to try to understand this growth in imaging because it's so costly. But the concern about the safety of imaging ties in very closely with concerns about the rapid rise of imaging, as both work together, from my perspective, to lead to this rise in radiation exposure. We're doing more tests, the dose per test is going up, and I think the population is feeling it in terms of the increased radiation exposure. From a perspective of the health insurers, or CMS in particular, they're very interested in appropriateness and quality, and some of their initiatives tie these two things together. This is looking at that HMO population in terms of the exposure to medical imaging. This is showing the effective dose on an annual basis for patients who fall into the highest 1 or 10% of exposed population. So these are the highest exposed people. This is the median survivor of Hiroshima survivors, and this is 1% of the HMO population have an exposure each year that's approaching 100 millisieverts. So as exposures go, these are really high exposures, and they're surprising. So there are lots of factors that have contributed to the increased utilization of CT. I think foremost is the improvement in the technology. In the right setting, there's no way to compare CT scanning to any other test. It's fast, it's accurate, it's a great way to get an overview of lots of things that can be going on. But this is not the only factor that's led to the increase in imaging. There's a lot of increased capacity that's the result of a proliferation of equipment, and when you have equipment, we all know you have to use that equipment, and so that's really one of the drivers of imaging. From the patient's perspective, there's no perceived disincentive to undergoing imaging, and there aren't really any other tests that can compare with CT in terms of volume. You can't do that many MRIs on the patients we currently do CT. So if patients want high-tech, the best imaging, CT is perceived to be that test, and there's been no perceived disincentive. For physicians have a very high demand and often want to see the imaging test before they're even willing to see a patient. Malpractice concerns are relatively high, and therefore concerns about protecting yourself against being sued have led to defensive imaging. There are relatively few studies that have quantified this, although when physicians are asked, they report unnecessary medical imaging due to malpractice concerns more than any other non-indicated medical procedure. And then lastly, it's very profitable to use medical imaging. It's profitable for the hospitals, it's profitable for outpatient facilities, it's profitable for the people who own the machines, radiologists, urologists, cardiologists who are buying them. And there's not a lot of disincentive to use imaging, and so clearly the cost comes into play. I think the most important factor that really has led to the drive of imaging is the fact that there are very few guidelines for imaging. There are some guidelines, but these guidelines tend to be very imperfect. They're based on consensus expert opinion rather than any data whatsoever. And so even the guidelines that exist, no one tends to follow them. And the lack of evidence, the lack of guidelines, uncertainty regarding when it's appropriate to image patients has resulted in excessive use. I think reducing inappropriate imaging is really a shared responsibility between the radiology community and the referring clinicians in terms of when should we image, how do we improve the use of imaging, but I think there's also a role for additional input by the payers and health policymakers in this area. And I mentioned the costs of medical imaging have gone up. In the context of this HMO environment, we found that patient costs related to imaging have tripled over the last 15 years. We also found pretty dramatic differences in costs across the different health plans in what kind of imaging tests they use, when they use them. So some facilities use MR for something, others use CT, some image at 3 times the rate of others, really desperately calling for some comparative effectiveness work to tease apart when imaging is appropriate and effective and cost-effective and when it's not. Related back to the radiation dose, we found the same variation in the radiation dose as we did for utilization and cost. So what needs to be done? I think medical imaging is an integral and very important part of medical care. However, I think there's real need for some evidence-based guidelines about when to image, particularly to stop the default of over-imaging. Research is desperately needed on when and how to image, meaning how do we set standards around the radiation dose and how to do so at the lowest possible doses, not necessarily to generate the most beautiful image, but to generate the most clear, accurate diagnoses. And I think a lot of efforts are needed to standardize and reduce the doses that patients are exposed to per study, and we need standards, to reduce the number of studies, to educate patients and providers about the risks and benefits of imaging. And I think there's a lot of fear in this from within the radiology community that if we talk about this risk of imaging, we're going to do less imaging. And I think that is certainly true. We will do less imaging, but I think there's room for less imaging. So I think increasing the appropriateness of imaging to have this more be a dialogue where patients understand that there's some benefit, there's some harm, they need to take ownership that it's not a completely perfectly safe thing to do. And I think we also need research to directly assess the risk and benefits. So moving on to sort of why I think there's a role for health policy in this, why is radiation safety in this category where there is a role for health policy? Ensuring the safety of clinical practice in the U.S. is generally under the domain of professional organizations. There are a lot of professional organizations of physicists, of radiologists in this area. I think the evidence in the last few years of both the radiation overdoses, acute radiation toxicity, as well as the degree of practice variation highlights why current practice organizations are not sufficiently taking care of this issue to ensure that we're safe. Imaging is really big business. There are about $100 billion spent each year on medical imaging. And the medical imaging community really has not been willing to take on this issue. So I think they have a lot of incentives that definitely in some ways overlie with the values of the American public. I think for radiation safety, we haven't seen this be the case. Clinical practice groups have very conflicting goals and incentives around both utilization and radiation dose that I think makes it very difficult for them to be keepers of radiation safety. I think there's also reason from my perspective that this provides a great opportunity for health policy intervention in that this area does have oversight in many other countries, and it's really done a very good job. So government oversight of radiation does exist in many other countries. It's a very successful model, and thus it's not that hard of a stretch for me to see that perhaps having that kind of oversight in the U.S. would be a very positive thing to the quality of care. There is as well a precedent of government oversight of radiation as it relates to screening mammography. This came about through a very different historical time frame, but mammography quality is overseen very closely by the FDA on the basis of the Mammography Quality Standards Act. So we have a situation where there's legislation, where there's FDA enforcement, and where this has really had a very positive impact on the utilization of mammography, on data around mammography, and radiation dose. So I think we have a model for within radiation safety where government oversight has been, I believe, a very positive force to improve the quality of this area of imaging. So in terms of how I moved into health policy, where that's really not the place that I've come from. My research over the last bunch of years has focused on clinical and health services research, not health policy. I had the opportunity last year to be a visiting scientist at the National Cancer Institute. I was based in the radiation epidemiology branch, so I was sitting among the scientists who have written most of the pivotal studies about radiation science, and I was based there to learn more about radiation measurement, radiation risk assessment. At the time our Archives of Internal Medicine paper on radiation dose variation came out, it turned out to coincide very closely with the radiation overdoses at Cedars-Sinai and then other hospitals, and that led to intense public interest. So our publication came out just by chance, very much the same time as this other issue that raised radiation safety issues. And then further, since I was based at the NCI, I had proximity to government decision makers, which was really an eye-opening experience for me that I wanted to share a little bit, that helped me appreciate how many different ways there are to impact quality that really happen in the healthcare policy arena outside of simply research. So again, the timing of our publication was really very fortuitous. There were many media reports of radiation overdosing. The dosing errors related to CT led to exposures that were 100-fold higher than needed, resulting in acute radiation toxicity, hair loss, memory loss, the kind of problems you get from radiation treatment from brain cancer. In fact, the radiation dosing from CT was equivalent to the kind of radiation you deliver for cancer. Unrelated to those radiation overdoses, there were a series of articles in the New York Times about radiation overdoses from therapeutic radiation. Pretty dramatic cases where patients were sick to begin with, but then had acute radiation overdoses that led to their deaths. And so there was a lot of public awareness and concern regarding radiation, and in that context, our paper describing variation in dose, that it was higher than needed, came at a time of this interest. I spent quite a lot of time at the time our paper came out speaking with the media, and the media were very interested in learning more about this issue. And I really have come to believe that the media is a fantastic venue to try to get different organizations to begin to speak to each other. And this is not so much to get attention on our work, but rather to get knowledge brokers about the topic to start to discuss the issue and to help disseminate information. And I think the media has a really profound impact on educating both the public, but as well public professional societies and policymakers. The policymakers read the same newspapers as we do, and they have a really strong influence on what they think. And their interest in radiation was broad. They really wanted to understand the underlying issues. And again, I think the more people that are aware of any issue, the greater possibility of having all these different people who I'm going to come to next help lead towards creation of public policy. So I committed quite a lot of time to help educating the media, and again, not to get coverage so much of our paper, but just to get coverage of the issue. And then I mentioned, by being based in DC, I had the opportunity to speak with lots of playmakers. There are lots of different kinds of organizations that have a role in shaping and influencing policy as it relates to issues like this, technology assessment, medical safety. And the groups that I identified that I think had really an important role to play, and I tried to work with each of these organizations and have ongoing relationships with each of them, are the groups that I thought could really lead to improvement in safety. So I'll talk a little bit about what there's a congressional legislative opportunity for change, what can happen at the FDA or what has been happening at the FDA, my attempts to try to influence quality through working with quality organizations such as the NQF, work with professional societies, which I think have a huge role in this area, ongoing discussions with CMS, the Institute of Medicine, and then industry. So in general, in terms of influencing healthcare policy, this very confusing graph is meant to be confusing to show you that there are a lot of different players in the healthcare quality world, the healthcare legislative oversight world. Policy doesn't come from one or another organization. There's no organization that can do any of this by itself. And the more crosstalk that I was able to generate, I could see it leading to really important discussions. So I have historically only been in my own relatively small bubble with research, but I personally made an effort over this year to really try to get out and interact with these other groups, help them work together, and I think that was really very informative for me, and I think potentially can have an impact on quality. So starting sort of with the U.S. House of Representatives, the U.S. House of Representatives Energy and Commerce Committee held a hearing last year focused on medical radiation exposure, and that opened the door for possible federal legislative oversight of radiation used in medical imaging. Given the very positive impact that I perceive for the Mammography Quality Standards Acts on mammography, I felt and tried to work with the Energy and Commerce Committee to see that similar legislative oversight for CT could potentially provide FDA with the tools they need to improve the safety. So I was approached by congressional staff regarding our work when our papers came out describing medical radiation. The congressional staff is really interested in talking to scientists. They're very available to be approached by scientists with the understanding that we only have a single voice as a scientist. It's not a particularly unique voice. They care about lots of voices, but it is one voice among many that they're interested in hearing about. And during the course of several discussions I had with them, they asked whether I thought it made sense to have a hearing to basically put on the record some views about this topic, about whether there was need for more work in this area. I had no previous discussions or experience with the legislature, but I thought it could be an extremely useful place to start understanding the topic, and I said I'd be, very pleased to participate. The hearing was very broad. It was radiation in general, not just medical imaging. And I approached that opportunity to really try my best to give a very simple message. And that message is, what is the problem? Why is this a health policy question? And what were some recommendations about what I thought they should do to try to improve the situation? So in terms of my testimony, I explained, I think, in the simplest terms I could, what the issue was. And the issue is that the number of people exposed is high and that the risks are potentially high as well. I highlighted how oversight is extremely fragmented, that the regulatory environment basically is non-existent. And so the FDA has some role, but not enough to fix the problem. Professional societies have some role, but they haven't done very much. And that there are some standards, but not enough, and there's no monitoring of how one keeps to those standards. And then I outlined what I thought should happen to improve the safety of CT. I think legislative oversight needs to broaden, quality standards need to be developed, and there needs to be greater FDA oversight. I also think public reporting is a key area that needs to be taken on. And then I also thought that a consortium needed to be created with diverse stakeholders to study this issue. I also used my opportunity to be, when I was in D.C., to really try to make more inroads at the FDA. The FDA last year, mostly in response to the Cedars-Sinai cases, launched an initiative to try to reduce unnecessary radiation from medical imaging, and they specifically focused on CT, a little less on fluoroscopy. And they began to engage the manufacturers and professional communities on ways to improve the safety of medical imaging. Their initial focus was on promoting the safe use of medical imaging devices, supporting informed decision-making, and the need to increase patient awareness of radiation. I was really struck when I learned more about how the FDA works in terms of what they can do and what they cannot do. The FDA is in charge of radiation safety, so this falls within their area, and yet they have remarkably little oversight on what actually happens with the machines. They're responsible for approving a machine, so a machine can't be sold until it's approved by the FDA, but there's no legislative mandate on what's focused on how these machines are used in clinical practice. And I thought that was a real problem at the FDA, given that we had so many examples of how the machines were not being used. I worked very hard to figure out who were making decisions at the FDA. I contacted the FDA. I spoke several times, both on my initiative, and then I was invited several times to speak to various size audiences, ranging from 5 key decision makers to meetings that they sponsored that had 500 manufacturers at them. And I really emphasized the need for standards. And several of the recommendations were adopted into their white paper on radiation safety, saying we need standards, but not going so far as to say we will create those standards. So they say we need standards for how to conduct CT, organizations should create them. So from my point of view, it was a little bit disappointing, and they just didn't feel that that was within the area of what they could control. So the FDA has encouraged the development of these diagnostic radiation reference levels. Those are basically targets, what kind of dose we should use. They're encouraging the development of evidence-based guidelines for how to use imaging, and they're saying other groups need to take the lead in this. So in terms of who these other groups might be, I think the FDA in the end may take on a larger role, but they need legislative oversight to do that, and that's not happening in the next couple of years. So the FDA clearly identifies the need for these standards, and I was trying to figure out who should write these standards, who should enforce them. And I didn't know about these kind of organizations ahead of time, but there are a lot of groups that their business is writing standards. And these groups have a very large impact on setting standards and then adhering to those standards. So one of these groups is a group called the National Quality Forum. It's a very large group. It was just my ignorance that led me not to know of their work ahead of time, not their lack of work. This is a very large nonprofit organization that's specifically focused in this area of setting standards. And they actually have a very large impact on the implementation of guidelines and really evidence-based practice. They're a consensus organization, so they have a very large group of stakeholders across really every area you can imagine: payers, providers, hospitals, the public. They endorse national standards for measuring and publicly reporting on performance, and they promote reaching these standards that are set through education and outreach. When NQF or organizations like this adopt standards, the impact can be enormous. The standard development process is pretty difficult. Lots of people submit standards, and these are often rejected. To be a standard, it both has to be adopted by all these stakeholder organizations that are on the various committees that assess them, and they have to be broadly applicable, they have to be very easy to apply, and they have to be validated. You have to show that they would really lead to improvements. So I worked with NQF to submit a metric that would basically ask hospitals and facilities that conduct CT to start to collect radiation dose information on consecutive patients. I'll just spend another minute. Sort of other outreach efforts that I worked on involved sort of working with industry, obviously a very important group. They have the most, I think, to gain and lose around issues of radiation safety. Professional societies working with sort of these national committees to try to set standards. I've worked with the IOM. I was commissioned to write a report on radiation safety and breast cancer. And then I'm working very closely with the integrated health plans that my research is based in, and they've been very receptive to changing practice and issuing guidelines for appropriateness of imaging. We don't yet know the impact, but I've been very impressed that they've really been open to both efforts to lower dose and lower utilization. The last thing I just wanted to sort of emphasize is how I envision policy could help in really the short term. I think there's a desperate need to monitor doses. If you don't know what you're doing, it's very difficult to improve it. I think facilities need to monitor the doses they're using and compare it to standards. I think someone at each institution needs to be responsible for these doses, collecting data, assessing data. This has been done in many other countries. And California in August actually passed a bill that would require exactly this. It would require recording of dose information on every CT exam. It would require sending the details of that, of the technical factors, to send to the medical records in radiology, as well as the general electronic medical record. Doses have to be verified to make sure that they're valid. And then the radiology information gets transmitted to referring clinicians through the report, and that has to include dose information as well. So there's a bill that just passed in California, and I think it's sort of moving in the right direction towards making us aware of the issue, and I think will improve the radiation doses that patients are exposed to. So I think there's a very clear connection between having a health policy solution and what I hope will be a real improvement in the safety of imaging. So in general, how to improve imaging, I think we need a a multifaceted approach. Professional societies absolutely have to take a leadership role in this area. I just don't think that's going to be enough. I think the complexity of the issues and some conflicting motivations also requires a health policy approach, and I think that can come about through national legislation, state legislation. I didn't discuss much CMS initiatives, but there's several that are based on giving bonuses based on doing imaging in a correct and safe fashion, and then FDA guidelines, I think all could work together. And I think all those efforts need to both focus on reducing the amount of imaging as well as improving its safety. I really appreciate the chance to talk to you. Thank you very much for your attention.